everybody. Welcome back to the Second Opinion podcast. It's Katie and KT, Dr. Tewari here with us.
Hello, everyone.
We are actually going to be talking about me today.
Yeah, you're a registered nurse, correct?
I am for about 2 years now. Just renewed my license, actually.
All right. So, I think this will be an educational process, not just for myself, but for everyone out there. First of all, what does it take to become an RN?
You can actually become an RN without a college degree.
Really?
Yeah, I think it's called like an ADP program. You can just get your license.
Got it.
So you take a couple classes, and then if you pass the licensure tests, there you go. But your pay is lower, and usually you start at a company or a facility that will expect you to finish your bachelor's, and they help you pay.
Is that an
for
LPN?
it.
Is that the same thing?
No, an LPN is less school, and it's a different type of certification.
Okay. So
But I looked into them because I went to FSU, and at the time, they only, of thousands of students that they have at that school, only took 80 every once a year.
So if you didn't get in, that would have been an alternative.
Would have been it, and then you have to wait a whole year and reapply. So they only accept 80. They go from like 500 people applying. They cut that down to like 250 get an interview.
Yeah.
And then only 80 get in. So my first year, I did not get in.
So what route did you take?
So I actually...
So you took the bachelor's degree route.
I did. I went the bachelor's degree route.
So what does that entail? You do like pre-med courses or what?
Kind of like pre-med courses. It's all these prerequisites you need for about 2 years. Then when I didn't get in that first time, I got 2 minors, one in family and child science, one in psychology, solely because they were just similar coursework to nursing. I'm not going to go get like a business degree in the meantime. So I did those for a year. Hoped and prayed I'd get in. I did.
Mm-hmm. And how many years is the program?
It's 2 more years. So if you went
you finished undergrad.
I did. Undergrad's 2 years. Well, and then
3 or 4 years, whatever. Undergrad, right?
Technically, your bachelor's is undergrad.
I guess it depends how many AP courses you come into undergrad and how many years you could skip. But I think the traditional way is total, 3 to 4 years total.
4 years.
4 years,
2 years undergrad, 2 years normal grad.
So all right, let's say you finished undergrad 4 years. So to get your BSN and RN is an extra 2 years.
You just confused so many people. No, it's only 2 years for nursing school.
That's what I said.
I mean, you made it sound like 6.
No, I'm saying after 4 years of undergrad, you take 4 years of undergrad, right?
No.
Undergrad is 4 years.
Well, in your nursing's included in your undergrad.
The whole point I'm trying to make right now is
4
years. Yes. She needs to understand the mathematical concept here.
Oh, my God.
Undergrad is 4 years, and then you do 2 years of nursing. That's 6 years.
No.
Yes.
No.
Okay, then what's nursing?
2 years of undergrad, 2 years of nursing. I take 2 years of like bio, chemistry,
So you're telling
physics.
me, hold on. So, okay, let's start leaving a little more back. Mm-hmm. You're in high school.
Yes.
You're applying to college.
Yeah.
You already know you want to get your nursing degree. So you just do 2 years of undergrad, and then within that 2 years, you do 2 more years for your BSN for an RN degree.
And that is in a total of 4 years.
Okay, but
and then you're a nurse.
What if you don't know you want to become a nurse?
You kind of have to
undergrad.
know. You got to know.
Really?
Like when you apply to FSU, they say, what fields are you interested in?
So there's a track.
So there's a track.
Okay, that makes sense.
2 years of track. Then
I was trying to think of like you don't know because a lot of people may not know what they want to get into in undergrad,
total,
right?
You would be a nurse practitioner. Because after you're an RN, BSN, you usually have to work for a year or 2, and then you apply to nurse practitioner school, and that is 2 more years.
Okay, so let's say...
You can apply right out of school, but not that many schools allow it.
So let's say you have a lot of AP courses under your belt.
Could
you just skip undergrad and do 2 years of RN?
I did dual enrollment, which was like you go to college and you go to to your high school. So like you would leave the high school campus, go to college, and come back. But I actually had a friend in high school who is still a nurse. She's a labor and delivery nurse. And she did 2 years of all of the correct undergrad classes that you needed. She knew from the get-go, I guess, and graduated with her AA degree. Immediately got into FSU's nursing program when she's probably 18 or 19 years old and was a nurse within those 2 years.
She came out with a bachelor's.
She came out with her AA, associate's degree, and then went 2 years at FSU and had her bachelor's.
Okay, because she finished her RN bachelor's.
Yes. Yeah. So
wow, that's confusing.
Fast forward.
Oh my gosh.
I became a nurse and then moved down to Tampa and started working.
Okay. So explain to me, because I'm used to med school, residency and all this other crazy training stuff. So you become an RN.
Oh, you want me to rewind?
Are you doing clinicals during the last 2 years while you're RN? So you're doing sitting classes and you're doing clinicals.
You're sitting classes and you're doing clinicals. And it was kind of funny because they were so strict at FSU because I was in it during COVID. Like 1 year in, I was in COVID. So they wouldn't let us come into class.
I was going to say.
It had to be online. No, it was not easy because the classes were online, but you still went to clinical, a.k.a. the classes were online, but you still went on COVID units, hospital units, emergency rooms.
So you learned everything about COVID.
Yes.
Basically.
But like,
you didn't learn anything else, just COVID.
Their reasoning was, we don't want you to all come to class because we don't want to risk for exposure. Right. But we're going to send you and work directly on COVID patients, emergency room patients.
I see what you're saying.
We were like, what?
So your clinicals are by definition the last 2 years, which is during your RN.
And you do hundreds of hours of like public health, nursing homes, inpatient settings, outpatient settings, neuro, pediatrics. We did it all. We actually, because Tallahassee, I don't know if you know, but it's not the most developed area for being our capital of Florida. Mm-hmm. So the public health clinical, definitely, we went to very underserved communities and kind of saw how those clinics worked. I even went to a high school that had a gynecologist in-house because they had so many pregnant girls in their high school.
What?
They had like 6 or 7 pregnant girls. And so they would get...
This is Tallahassee?
Yeah, they'd get gyno exams in school because they were pregnant, still going to school in person. Pap smears, the whole thing. Because the county...
Was this a school for people in...
Normal people.
Okay, all right.
Normal people.
I got it, okay.
Crazy.
Got it. I understand now.
And then the county right next to Leon County, which is like Tallahassee, is number 1 in chlamydia in the nation.
I thought the Villages was.
No. Up there.
Okay. All right.
Yeah, it's pretty high up there. So that was good, like learning just to see like different economies and kind of how care was given. But then for our pediatrics, we went to Jacksonville. I went to Wolfson's Hospital. Because we didn't have like a great like pediatric experience in Tallahassee for that many students.
So you got all your training at all these different.
You get all your training.
Locations.
You have to hit because it's a board thing. Florida makes sure that the school makes you.
Right. Okay.
Then you do an internship. I did that in Orlando.
Is that part of your RN?
It is.
Within the 2 years?
I think I did like 300 hours, maybe more. No, probably more than that. And then you get your externship, I guess is what it's called, and that's finished.
So it's pretty straight through. It's pretty rigorous.
And then you probably have like 1 or 2 tests a week. It never really stops once you're like in the program.
Right.
And now they're doing accelerated programs where they probably have 3 tests a week, and you finish your RN from January to December.
Wow.
And you're done.
That's interesting.
Which I had somebody do, and they said it was tough, but I mean, you might as well knock it out.
Right, I was going to say, it's nice to have expedited options.
Yes, so definitely there's many ways to become a nurse.
Is that because of COVID, so they can get more nurses?
No, I don't really know.
Or was that always in existence?
I don't really know why they did that. But now the College of Nursing at FSU, they're allowing like upwards to 300 every time. I think they have more resources, they have more teachers, they have more classrooms. So I think money was definitely allocated that way.
Okay. So... you got your RN degree. You passed all those stuff you're supposed to pass.
Oh, yes. Then you got to pass your boards.
Okay, you pass your boards, and moving forward, then you find a job.
Actually, I want to focus on the boards. More? Yes. Well, the boards is nothing like nursing school. So everything you've done to prepare yourself.
Wait, hold on. But aren't all exams not really like real life?
Yes. Yeah.
Right?
Yeah. But this test is weird.
Okay.
I can't remember exactly because they change it every year. But you get like hundreds of questions.
Right.
And out of nowhere in your exam, it stops. It could stop at question. Like there's a minimum.
Oh, it's one of those exams. If you're answering all correct, it maintains that style of question. But if you're getting it wrong, it gets harder or something.
It's kind of weird. If you're getting it right, it gets harder. If you're getting it wrong, it gets harder. Or like you don't really know. Can't really tell. They make it so you can't tell. So mine cuts off. Like the minimum it can cut off. So I'm like, because when you take these exams,
passed it or you really failed it.
Yeah, I either got them all wrong or I did great. But these tests, you don't ever feel like you're doing great.
Right.
So then they don't tell you if you pass or fail. They love to just
How long does it take?
stress this out. They don't have a time frame for you. So you take your exam, it stops.
It take months to get your answers?
It does. It depends.
Oh.
They won't tell you. Mine took like a week. So I'm just sitting around twiddling my thumbs. I already had a job offer accepted, ready and lined up. Did all the paperwork for it. So now I'm just like a lot of stress on this test.
We had to wait 3 months.
That's awful.
Every exam. We had to take 6 boards.
Well, your boards are more extensive. Ours is
But you have
just
to still
an
wait.
exam.
I mean, everything's computerized. So, I'm sure the computer already knows how you did. It's just if they scaled or whatever. They throw out experimental questions, stuff like that sometimes.
Ours was at the end where they were like, this isn't graded, but this is what it could be for the future students. Please take it and take it seriously.
So did you get a lot of zebras?
On the exam, no.
Yeah, like stuff you normally would not see, but they just want to see your knowledge, see how well you know it.
No, and then they'll make the question so then like 2 answers are right, but really one's more right.
Yeah.
So that's behind me. You never have to do that again. Because when you renew your license, you just have to do a couple courses, but you got it at that point.
I think physicians is the only profession where you have to take a whole new damn boards every 10 years.
But it's important.
Lawyers don't have to.
Lawyers don't have people's lives in their hands, their hearts in their hands.
They do because laws change all the time and everything, right? You have to keep up with that. RN, same thing. I mean, you're in the medical field, whatever it is.
We take continuing education, though.
Okay, we take continuing education that we have to fulfill every year. And on top of it, you have to retake your boards every so years as well.
I agree with that. I'm disagreeing with you.
We're the only profession that has to do that.
I think
lawyers should do it too.
I don't think they should.
I think they should.
They're in a whole jury. And then the juror.
Sure, but what if you hire a lawyer and they're not up to date with what's changed?
You got a bad lawyer.
Same thing with doctors.
You're not going to die.
But isn't that the concept for doctors, though? The concept is, what if you're not up to date with this medication or disease? It's the same concept.
No. Well, nobody's dying.
Well, people may get thrown in jail for the rest of their life.
That's fine.
Or
they're alive.
What if they get the death penalty?
And nobody would get that.
Oh, really? No one? Okay.
Based on a bad lawyer, I don't think anyone
there's a
would
firing squad as a result. All right, we're getting off course here. So you get your RN, you pass your boards, and you did everything else that we just talked about, and you're applying for a job. And on day one, you get your job at your by definition RN, right?
Yeah.
Okay, so how does your first job, how do they train you when you're like an RN?
I think it's different everywhere.
Different. Let's say hospital setting, because
could be also different everywhere.
Okay.
Just the way that they do things. The one that I was employed at, you do a week-long orientation where you and like 100 probably other people that are part of this orientation, they try to hire a lot of people kind of in bulk so then they can do the orientation in a week.
Right.
Hire everybody for May, let's say.
But you already know what to do, right? Like orientation's like putting in drawing blood, putting in a Foley. Like,
honestly, no. Orientation is not really skill-based. Isn't that terrifying?
So what is it? Orienting to the place that you're going to start your job?
We did do a drug math test. So like making sure you know how to do calculations of drugs, which is good.
Okay.
If you didn't have a machine or you didn't have your chart to tell you how much to give the patient. So that was good. But no, you don't, for orientation, you don't put in IVs, you don't put in Foleys, you don't even do it on mannequins. Their expectation is you came from an accredited school and you had all these accredited hours of clinicals that you did. So they trust where you're coming from. So orientation there is kind of like the policy and protocols and procedures that they do at that location. If I'm being honest, and everybody who was also attending the orientation, it was pretty much zoning out the entire time. Because it's very long, very boring. It's all day long. They're just filling you information. So then you start.
Okay.
You actually start. You get on your unit.
So wait, you start, but do you have a mentor?
Yes.
Okay.
So you usually start and you have a mentor or preceptor. And
they call it preceptor, don't
either
they?
One. It depends. And you're with them.
And it's another RN who's been there forever.
Hopefully.
Maybe. Okay.
Nowadays, no.
Okay.
It's not. It's usually another new nurse. So that's kind of scary. But I had a couple different ones. I was kind of thrown around to a bunch of them because I don't think that it was very like organized in the way that it happened. I liked it in a sense where I was able to see how different nurses did things, but also I kind of kept taking like one step forward, two steps back because they didn't know kind of like how far I was learning or what I had already done.
Yeah.
So like you get all these skills check-offs. So your sole preceptor is supposed to keep track of like, okay, she treated a patient with a trach today. She treated a patient with a Foley today. She treated a patient with a stroke or with the brain bleed or a seizure. She did active seizure measures and they check it off.
Right.
To make sure that all of these skills that you're supposed to at least see one, do one, or what is it?
See one, do one, teach one.
See one, do one, teach one. They are supposed to make sure that I saw one, did one, and taught one.
Right.
Or exemplified to someone else, I did it without your help. That didn't happen. I don't think it really happens anywhere. I think people just get like a general, okay, she did it all. And then when you go and do the paperwork, everyone just checks yes.
But in your clinical training, you've done this stuff before.
No, honestly, like.
Never put in a Foley?
I put in a Foley.
Okay. What other procedures? Like, you remove sutures. You guys look at incisions post-surgically.
I never removed sutures. I never removed staples.
Is this because you trained during COVID?
I think so. But also,
or do other your colleagues say the same?
I mean, think about it. It just depends. Like, I had all my student friends, like when I was in school, I'd be like, oh, I put it in an IV. And they would go, what? And some people never put it in an IV. Some people were like, I took one out of a dead guy, but like they never got to do some of the skills other people did. It just depended on what patients you had that day, what kind of came up. But when you're in the hospital, they really try to make you see everything.
Right.
So this facility I was at, it was really nice. For one day, your 12-hour shift was divided into 3 different sections. One day you did endoscopy, which if you don't know, you just come in for a simple procedure and you go. But if you're going to go under anesthesia, to insert the anesthesia, you have to have an IV. So this is where they send you to just practice IVs all day.
Yeah.
And they know that you're coming to do that. So it was really nice. I did like 100 of them, and then you just feel confident.
Yeah.
The next 4 hours was the ER. So just seeing like emergent conditions and how to act on it quickly.
Right.
I didn't really see an emergent condition when I went to the ER because you just never know.
A lot of it's experience. In our field, you don't always, you don't predict what walks in the door, right?
Exactly.
So you don't know what you're going to get trained for or not or experience.
And there's always a team that you call if there is like a code. So you do what you can when you're there until they get there.
So you kind of observe and learn as it goes.
And then the next 4 hours was intensive care. So I went to the ICU. And they do a lot more bedside procedures than we usually do just because they have the opportunity to. So I saw like an NG tube insertion. So I got to see a couple things.
So for people out there, that's a tube that goes through the nose,
through
down
your
the
nose,
throat, which
into
is
your
the
stomach.
most painful looking procedure.
You want to be unconscious.
But a lot of times they're not.
You're not.
Yeah.
And I actually saw a lot of those on my unit after the fact. So it was nice that I got to see it. But it's just one day.
Right.
And then after that, you just shadow your preceptor. You hope you learn as much as you can. But there's definitely the stigma there where you're brand new. And then they also kind of look at you as like, you're kind of dumb. Or you're told you're kind of dumb. Which isn't a big like confidence booster.
Is that how you feel, or you think that that's what it's being expressed?
No, you're kind of being told, physically being told that.
Oh, in medical school, we were told in medical school, because we have to go through rotations, we were told that we are like the fungus and the scum at the bottom of the fridge. That
that's what you
better
feel
respect
like,
nurses, and you better because everyone knows more than you. But that's the same thing for any learning process.
You kind of feel like the scum when you get there because you're the student nurse. You're new. Like, oh, go pick up all the poop. Like, you go do all that.
We call it scut work. They're going to get you scut work.
They make you do that.
Yeah.
But it's like, am I learning? Sometimes. Sometimes it feels a little like hazing. But at the end of the day, it's
in my
everybody
opinion,
learns.
I think everyone should experience something once.
Yeah.
So, right?
Mm-hmm.
No,
But it is, though, you want a confident nurse. You want a nurse that knows what they're doing.
Heck yeah.
So if you're getting kind of knocked down a peg all the time,
right,
it's not helping. It's just making you feel maybe less confident what you're doing. Instead of more education and more like, oh, it's okay that you don't know that. I'll show you that.
Right.
Not, how do you not know that? There's a way of going about it to make better nurses.
But you know what? I think that's the medical field in general, right? Because it
it's
is
kind of
so
a hazing culture.
Yeah, it is. But it's so important to know this stuff that we come from a mindset of you don't want to look stupid in front of people. So you either read about it, you go ask about it, you go figure it out.
Mm-hmm.
Like that's the way we're used to. You have to figure it out.
I think it's sad sometimes, but it's true. You have to figure it out. But it is sad sometimes when you go through being a student nurse, being so scared, and then you go out in the real world nursing and you're starting out and you're like hoping that someone kind of like lends you a hand.
Do you guys ever get taught by physicians?
No.
See, I almost wish.
Some people are doctorate of nursing.
I do. I mean, like physicians, MD/DOs or whatever. I used to give to like educational pieces. And I think for people in all of the fields to learn about each other on a special topic, you learn so much more.
I mean, it's definitely
we interact
necessary.
no matter what all the time, especially with patient care, right?
And it's necessary to know what our role is and what your role is because...
But let's say you're dealing... I'm going to give you an example. A patient with congestive heart failure.
Okay.
You know that they have a lot of fluid, they're coughing, they're having difficulty breathing.
Like it's a test question.
You give meds though, right?
Yeah.
But do you know exactly like why you're giving this med? Yeah, sometimes you do, but sometimes you don't, right? Because there's meds, you know exactly why, like, you know, I mean, you're taught on terms of weighing them, giving them their medication, but like the anatomy behind it. Like,
well, that's because my preceptor said, like, don't ever give a med to a patient without telling them what it is, what it's for, and have they ever taken it before.
Right. So I think though, like, and I guess where I'm going with this is like, you know, having a different perspective from a different side of a profession and knowing, you know, what it's, you know, not just what it's for, what are the side effects for it, you know, what this can happen to you, you know, the importance of like the pathophysiology behind it. I know it's like, sounds boring, sounds like, you know, whatever, but you know, that's how I think people really understand something too, right? And I think it's important for everyone who's caring for the patient to really understand what's going on with that disease process.
So then think of me, okay? I'm like just finished my preceptorship. So I get through my preceptorship. I did it.
Right.
I'm on the unit. They usually start you out with like when you're by yourself, like they'll start you out with, well, slowly when you're still with your preceptor, they will get their assignment of maybe 5 patients. Which is a lot, but it's a norm now.
Right.
5 patients. And then they'll give you 1 of them. And then next week, they'll give you 2 of them. The week after that, they'll give you 3 of them. Like you work up to it. So then it's not like, oh, go there you are.
Right.
So then my first day, like just on my own, and I got 5 patients, I was like terrified. And I did it, and it was fine. And then every day got better. But it is scary to think about, like, over time at facilities, like 80% of the nurses are brand new. So if you think of
fact.
Yeah. Okay. So 80% of them are brand new. Okay. If you think of like new ones coming in and getting trained, the probability of them getting trained by another brand new nurse is like kind of high. It's kind of scary. Like I was trained up, but I don't think I should be traineeing. There's a lot still that I don't know that I learned every day the whole time that I worked. So it's just scary.
But also, when you're in a particular niche of a floor, there's, you know, you're not going to know everything, like of all of medicine.
Because you get floated around.
But you're going to know that niche, you know, pretty well, too.
And they don't float you, which is like going to a different unit. They won't float you to another unit until it's been like a certain amount of time. And the first time I was floated, I was terrified. I was so scared. But I went there and I was like, okay, it's pretty similar, but also nothing went wrong. I was like, I did good. I think I did all right, but it was scary to kind of get thrown into something you've never seen, or a patient condition that you've never treated.
Yeah.
But overall, like it was tough.
Okay, so then you get your preceptor, you get trained for that period of time, then you go out on your own.
Yeah.
And then what opportunities come from there?
What do you mean?
Like, you know, I guess, let's say you do med surgical floor, right? Which is a standard floor for medicine in a hospital. You have opportunity to go where? To the ICU. There's different types of ICUs, like surgical ICU, medical ICU.
You can start out ICU.
Oh, you could start out ICU too?
They do more training in the get-go.
Well, that must be much more, like, intense, right?
Oh, I thought you were going to say money. I was like, no, it's the same money.
Oh. Well, I was going to say intense.
I was going to tell everybody, like, any nursing you do, it's the same money. Any unit, yeah.
Unless you're doing a night shift versus a day shift.
Night shift, yeah, you get the differential of the pay. But like, say I'm on a neuro floor or a cardiac floor, you get the same pay.
But a lot of people love to see higher acuity, sick, you know, situations.
Higher acuity, you have less patients.
Less patients.
So same pay.
Right.
It balances itself out. Like you only have 1 to 2 patients if you're in the ICU, which is like you should only have 1 to 2 patients.
I think I would do that.
Everyone has their preference.
I want to get 5.
I mean, 5 is a lot. And when they are high acuity 5 or like high intensity 5, it's a lot. But
so, okay. So then, I mean, most people stay in RN the rest of their lives, right? I
Yeah.
mean, so where's there room to like build up and grow up from?
You can be a nurse educator, which is supposed to be the person who educates the unit, clearly. But they also take the newcomers in. And they set them up with like a binder, and it tells them like every skill they should learn.
So they walk with you, they teach you, they do all that stuff. Yeah,
they're supposed to. Yeah.
Okay.
They're with you, and they kind of do little check-ins with you every so often, and make sure that they're feeling comfortable because it is such a big switch. And then you could also be a nurse manager. You could be doing the nurse for quality metrics. So we had a nurse on our unit who tracked. The facility would give them the numbers of like how often are we documenting that we're cleaning the Foley? How often are we taking out Foleys? Like
infection on floor,
infection
stuff like
prevention, just the quality metrics of how many maybe incidences do we have, like falls. So there's little leadership admin roles you can do to move up. The biggest probably would be nurse manager, and then for the whole unit, and then above that, the director of nursing of the whole hospital. But there's so many different jobs you can do with having your RN.
You can become a case manager too, right?
So I was going to say that. Yeah. Case manager, social worker.
Care navigator,
kind of what I do now. Yeah. Just tracking length of stay, trying to reduce the length of stay, trying to reduce patients coming back, getting readmitted. Maybe trying to track why are they coming back? Is there a trend there? Right.
Or you could go to nurse practitioner school.
Oh, yeah. Or you could further education and get your advanced practice registered nurse, get your master's degree.
Become a provider.
You become a provider. There's a lot of options. Which
seems like everyone's doing that these days. So.
I don't know. There's a lot of people that are like, that's not me. I couldn't do that. And it doesn't mean that the RN is lower in any way.
No, of course,
It's just a different career.
Right.
Different role.
Right.
But the RN can do so much.
A lot of people like to be in that educator role too.
Yeah. Because or you could even go back and get like another degree and become a professor. All my professors were RNs.
Right.
Because they go back and teach, or they're adjunct professors.
Interesting. So you did all that, and I guess opportunity is there's this thing called travel agent, right? Or travel nursing. And that's a lot of money though, isn't it?
Nowadays, I honestly think it's getting lower. So I worked with a lot of them.
I mean, COVID really exposed that.
For taxes. So you think you're getting more, but you're going to owe a lot too.
Because you're traveling out of state and everything.
Everything's different. But so I worked with a lot of travel nurses.
Right.
On my unit because we were short-staffed. So we would have like a contracted travel nurse. Sometimes it'd be a different nurse like every so often, like every other day. But some of them were contracted. On our unit, we got to know them. They'd be there for 8 weeks or so. And it was tough. Sitting there getting what I was getting an hour and them doing the exact same work, or maybe them getting like an easier. And
they're going to a new city, enjoying life too.
Yes. But like if they got an easier assignment that day, like maybe a couple of the patients were like easygoing or nice, or it was frustrating to sit there, get paid my wage and sit next to them and them keep talking about what they make and what they're doing on their free time and how much they're traveling and vacationing, and it was frustrating.
Well, I guess that's why there's a big paradigm shift in people going into travel nursing, right?
It's such a bad cycle. What's going to happen is it's already happening. All the bedside nurses are leaving.
Well, that becomes a staffing issue for hospitals, right?
Exactly. So all the regular bedside nurses are leaving, going to travel nursing. The hospitals are now having to pay way more for these travel nurses, and then it's just going to keep happening. I don't know how they're going to end it.
I believe that the state, and I don't know if it could be federal, has started to put some more stricter guidelines on like these travel agent nursing companies. Agencies to restrict it a lot more.
It was scary too. I forgot to say that these travel nurses, not all of them, but there were some that it was very easy for them to say that they may have done some type of experience, but they actually did not.
Right.
So you'd have some maybe underexperienced nurses that were saying that they were higher experienced. So it's a little scary. You don't really know where they're coming from. You don't know their credentials. Like our unit didn't interview them. The hospital interviewed the company that employs the nurses. There's a lot of telephone game played there.
Yeah. But I guess at some point you have to say, well, we have to accept it, right? It's just the way it is. It's a staffing issue. I'm assuming you go to tech companies or somewhere else. There's, due to lack of staffing, there's people who probably come in, get paid a lot more at a different rate, and they're just to fill a spot or a void for a period of time.
Yeah. I mean, I don't know how they're going to fix that bad cycle, but the pizza isn't going to cut it.
The pizza you guys order on the floor?
No, they always, you've been working so hard.
Every hospital does that, though. I've seen every hospital do that.
It's a meme now because it's so bad. Yes. Oh.
But, I guess
we're so sorry.
You think it's cafeteria food is, logistically has been, it's just you're working so much, you don't have time to eat, right? So here's the pizza. It's right here in front of you. It's on the floor, and it's outside, Papa John's or something, right? But
it's like you're understaffed. You're underpaid. I know.
Here's pizza.
I'll give you some pizza. That helps.
Sometimes you get like other perks, right?
No.
Gift cards. No.
Like a $5 gift card.
Yeah.
So they actually raised our wages when I was there. I wasn't sure if I should say it, but I probably made a good, whatever, like 1% raise, 2% raise. Any raise is good when you didn't even ask directly for it. And the whole facility got it. Mm-hmm. Super exciting. I actually started working for this company like before Christmas came around for the past company. And they did give that raise, which was great. But then when it came around to Christmas bonus time, they would always give a bonus and they'd always give a gift card to one of the grocery stores that everybody loves. And they actually sent out a notice. They were not doing it that year.
Yeah.
So it's like, awesome. Stay here. We're giving you a raise. But then the expected gift you usually get at the end of the year, we are not going to give you that. So it was all, again, one step forward, two steps back. It's like everyone was happy, but then they were also frustrated.
Yeah, I think that's a medical career, everywhere you go throughout the country.
They're definitely working on nurses' wages. I know they're working on the staffing. It's not like an easy, snap your fingers, it'll be fixed.
I think bottom line, it comes down to all the insurance companies that are cutting down reimbursement. It's affecting hospitals, affecting doctors, affecting everything. And ultimately, it stems from one thing. It's just they keep cutting back to government, and everyone gets getting screwed in that process.
Insurance companies ruling the medical field once again.
Exactly is what's happening.
But overall, the nursing profession, it's such a good field to get into because there's so many. I didn't even list probably hundreds more jobs that you can have as a nurse.
I mean, you're always going to have a job.
Always.
We look at physicians like, hey, we're always going to have a job.
We didn't even say you could work as a school nurse.
You could do anything, right? Yeah.
You could work
in a nurse. You could work for a company.
Urgent care.
You could work for an IV place down the road for people just inserting
IVs
I did do that.
All day. I forgot to mention.
Oh, really?
I worked for an IV company. I managed a couple nurses, and I would dispatch them out to these houses to go and give IV bags to.
Sounds like fun.
It was a lot of work though. I would be at work sending a dispatch for the other work.
Right.
I was like, I can't do this.
I think if I was a nurse, I'd probably like ER the most.
I would too.
I think that's
I wish I did ER.
The angle I would go.
Because you have the patient and then they're gone.
I do, but I do notice that because I see nurses on the floors all the time. I see in the ER. I don't know. To me, I feel like the ER nurses are so much more happier, and they seem to be such a good collection of I would picture them doing stuff outside together, and doing happy hour together.
You mean the culture of them?
Yeah, I mean I don't know. I just feel like they seem to have a much more different vibe.
And the med-surg nurses are miserable.
Yeah, I mean you're seeing 5-6 patients, and sometimes more or whatever, and those patients are sick. But at least in the ER, look. People come in, you deal with the situation, and it's dealt with appropriately in a manner of either going home, being discharged, or saving a life, like a trauma coming in. I mean, you're always on the go, so you don't have time to think much,
Well, ER nurses, too, it's you assess, you treat the patient, and then as much as you can until they're moved to another unit.
Next situation.
If you're on a med-surg unit and you get that patient, you have them forever, and they never leave.
Right.
So the ER is oh, this patient's kind of troublesome. Right. It's all right. I'm only going to have them for 30 more minutes. And then they're gone.
Right. Well, and
you
also...
don't really have a choice on the med-surg floor.
But also you're doing probably a lot of drama in the ER too, right? druggies coming in acutely. And,
I mean, the druggies that come in are just going to get moved up to our unit. We have them
but
too.
by that time they're withdrawing. But, you get the violent stuff. I mean, I guess what I'm trying to say is you see everything, and to me, that'd be pretty cool.
You do see everything like right when it's presented. When we get them, like they've already had some intervention done to them, like, whether it be surgery or just the overall like admission.
Right. Yeah.
Definitely interesting. I didn't even go into. You could go into the pediatrics.
Yeah.
Which comes with its ups and downs.
I don't think I could do pediatrics.
Mom and baby, labor delivery.
I'm sure that sounds like it'd be fun.
You could work in post-acutes with some geriatric patients, which I thought I would always do because of my grandma. I always thought that they need more people who have hearts for those people.
Yeah. I mean, the post-acutes, as you know, those facilities can be tough, right?
I mean,
staffing, I'm assuming if the hospital has low staffing, those places can have low staffing even more, right? I don't know if they pay better or not. I don't know what the difference would be on that, but yeah.
Very close. Everything's pretty close. So that's kind of the beauty of nursing too. Like anything you pick, it's not like you have to decide based on pay. It's going to be similar wherever you go.
Right.
It could be differing hours because as a nurse, you're going to work those 12-hour they're really like 13, 14-hour shifts.
Well, you got to choose your schedule too. That's one good positive thing, can't you?
No.
Like you do 3 shifts a week, but I could do 5 if I want to make more. Or,
you could add shifts.
Or you could even subtract. Can you not?
Mm-mm.
Oh, you can't. So once you're committed 3 a week,
you have to do 3 a week.
Oh, okay.
If you don't, you're considered part-time.
But then you can choose to get your weekends off. You could do like
kind of
Monday, Tuesday, Thursday, and have like a 3-day weekend with a little.
That's the only beauty of 3 days a week is that you never have to use your PTO. Or your ATO, whatever people call it. You don't have to pay to get off. You usually can just finagle the schedule and like ask your friend, will you work Friday so then I can like get off this weekend and I'll work your Thursday.
Right.
So that's amazing. But it is too, like you work 3 12s a week and everyone's like, that's so easy. It's like, no, the day after your 12-hour shift, you're hungover from your shift.
Right.
You didn't drink, you didn't sit down, you didn't eat. You didn't pee because you didn't drink. So the next day, you're so dehydrated. You're so exhausted.
I think they should put this podcast in a recruiting, at the university to get people into RN here.
It's got its pros and cons. Like, it's exhausting, but, I mean, you do know that you're going to have...
It's rewarding, though.
Yeah, it is. It really is. You do make a difference in so many people's lives, and a lot of people do tell you.
Yeah, I mean, it makes the biggest difference for patient stay.
Oh, well,
right? I mean, it's huge, right?
I will be a big old nurse advocate. We do everything.
Right. I mean, you talk to families, you deal with the patient, you deal with the, active situation that's at hand of what's going on.
Oh, so we assess the patient. We let the doctors know what's going on with the patient.
No, you guys
we
are
do
eyes and
anything
ears.
the doctors tell us to do, aka orders. We carry out the orders.
Right.
We are electricians sometimes. We are secretaries. We are housekeeping.
Yeah.
We are. I saw this thing, and a nurse is.
So are you saying that all RNs should get raises? Is that what you're advocating for?
Big ol' advocate for
I'm
it.
not denying that at all. I agree with that.
I just think we do so much.
I agree.
We're bodyguards sometimes, security guards sometimes.
Martial artists.
We're therapists sometimes.
Yeah.
We're psychiatrists sometimes. Like, I saw this thing, and it literally was just a list of things that a nurse is, and it's like, and that's just a day in the life.
I'm sure there's a lot of TikTok stuff out there.
Oh, yeah.
About it that probably are
it's like
funny, but yet true.
Well, the things that you get told, too, because sometimes, like, as a nurse, like, people look at you, and they don't really look at you as a human. So they'll say things to you and, like, kind of verbally abuse you and just not really thinking, like, oh, there's a person behind that.
Right.
So the things that we've been spoken to, like the way that we've been spoken to, and it's like you're writing your note to chart, and it's like patient told me to go F myself. Patient told me to like go die or something. Like they're very MD made aware. Like that's our life.
Yeah, I mean that helps though because it helps show the mental status or situation, what's going on with the patient
like,
before we walk in too.
Patient threw his remote and bucket at me.
Yeah.
Like, security called.
Well, I definitely know I've been warned that there's pee all over the floor or other substances all over the floor before. So.
You definitely, if you're debating going into nursing, have to be ready for seeing a lot of fluids of a lot of sorts.
I think the most intriguing part is, though, every day is different, right? People who go to work and you sit at a cubicle or you do this and that, like it's monotonous, right? There's definitely, I would say, an adventure associated with this type of field, though.
Yes. Oh my gosh, yes. I've never remembered 2 of the same day.
Yeah.
Ever.
And some days are just like, I mean, I know it depends on your patient load and depends on your type of patients, everything else. But, there's days that are, I would say not as stressful, I'm sure.
And that's why I think, too, that it's important for doctors and nurses to maybe shadow one another, because a doctor might order something 3 times a day or order something at 9 a.m. where it's not going to happen at 9 a.m. It's just not. Right. So it would be helpful for them to know, like, what's a busy time of your day, what's not.
Well, and argument of that, I'd say, a lot of meds, though, are time dosed and important. Yes.
I wasn't talking about meds. I'm going to give a medication when it needs to be given.
Yeah.
But say they want an enema, okay, and they're wanting it at shift change. It's not going to happen at shift change.
I don't think I've ever written for an enema at shift change.
You just never know. Sometimes it might have been happening.
Really?
I don't know. There were just things where it was very poorly timed. Like, let's bladder scan the patient at 6:30.
Yeah. And I guess for people out there, you guys have shift change and have to sign out all your patients and educate the nurse about the patients that are coming in and stuff like that. Yeah.
That's huge.
The handoff, right? It's a big part of communication and everything else.
You leave at 7 p.m., but you're exhausted. But you then need to hone it together, recollect everything that happened, because it's so important, because then that could delay care, that could really cause a bad outcome if someone wasn't notified of something important that happened that day.
Yeah.
Because it's not always right in front of you on the chart.
Yeah.
Sometimes you have to do some digging.
Well, that sounds like a lot of trials and tribulations in this whole process, but in the end, it's rewarding, right?
It is. You really do a lot. You do everything. So when you see somebody progress, especially on a neuro floor, because it is so personality based. Like, if you come in and someone has a traumatic brain injury, they can't move, they can't speak, they can't eat, they can't pee, they can't do anything themselves, and you see them progress from nothing to a totally functioning human being, and they're going home with their family.
Yeah,
it's great.
It's crazy.
That's the best.
Yeah. That is definitely something that, like, when we walk in and, like, this is a different person today.
Yeah. Because you guys usually work for a week straight-ish, and then a week off, you come back totally different.
Wow. Yeah, that is definitely... That's why I like higher acuity, because you actually see changes that happen throughout, seconds to minutes to hours to days, right? Yeah. And you can actually see medical treatment making a difference and medical care overall.
Yeah. When you see the system work.
Yeah, it's a beautiful thing.
It is a beautiful thing.
Yeah.
Not often, but it's not rare either.
And it works a lot.
It works, but it's there's a lot of hardness. There's a lot of hard ones that don't make it that well in progression. Yeah. Just with a TBI in general, traumatic brain injury, sometimes you can only progress so much.
I think anything in medicine in general. It's like they say you have a soccer goalie, right?
A what?
There's a soccer goalie, let's say, right? Okay. Everyone always remembers the goal that scored against the goalie. They don't remember the amount of saves.
Like all the saves that yeah.
Right? I mean, and that's I always say that. I think that's very important for people to know. Like, we save a lot of things all the time. No one ever looks at that part of it. But the one time you get scored on, that's what everyone looks at, right? So
that's what affects you the most,
right,
too.
100%. But, that's, I guess, even though there's bad, there's still good that manifests out of what happens. And I know it's hard for people to realize that, but
I think it is. I think it'd be helpful if, like, nurses were kind of getting some morale boosts every once in a while, because it does you kind of get stuck in that air conditioning, fluorescent lighting, and you kind of go a little crazy.
Well, maybe they should do transparent roofs, and then you have the sunlight coming in, and that may help people's mood and vitamin D levels, too.
You think there's going to be a hospital with a transparent roof?
Maybe we'll make one. I don't know. That'd be kind of cool.
Maybe.
And then you push a button. If the patient can't tolerate it, then you just, you have it closed in that room. Not a bad idea.
Well, for now, we need some morale boosting, something a little bit better than pizza.
Yeah, right. Well, on that note, thank you for sharing your experience and passing it on to the public in regards to what it takes to become an RN.
Yeah, Katie Coons RN, signing out.